So, um, I want to, I don't really have a lot of technical material, but I have a little bit, but I just want to start by saying how, like, confused I've been about all this stuff. So a couple months ago or a few months ago, coronavirus was a distant problem. Um, as late as um, February 28th, you had a leading political economic commentator saying many people will take precautionary steps, canceling vacations, refusing to fly, avoiding whole nations, even if there is no adequate reason to do that. Those steps can in turn increase economic dislocations, including plummeting stock prices. So as late as 28th of February, people were telling us that we shouldn't do anything because it might hurt the stock market, and which is kind of connected to this general idea that if the economy goes badly, will be killing the golden goose that gives us health, and all of that. Now, I think in many ways, the discussion in the news media about all this was a failure of social science, in that um, all the actions being discussed were individual actions. So should we stock up on toilet paper? Should people take their kids out of school? Should people hole up in the country? A set of individual decisions. Um, and and I was kind of thinking about this from my own perspective. So when my family and I heard about these things in February and then in March, there was a growing drumbeat of concern. It wasn't clear what we were supposed to do. I didn't talk to anybody who said, oh, what we need is a massive testing program. I hope the government's ordering 1 billion tests right now, et cetera, et cetera. Now, why was that? I guess it's a kind of division of labor that we trust the CDC to fix everything for us, and then we live our own lives. But I mean, imagine if we thought of public health in this way, that we just gave advice to individual people about how to get treated the best way. That wouldn't solve our problems. Imagine that you were trying to fight a war, and you fought a war by telling everybody to stock up on canned goods and have a gun in their backyard. Probably wouldn't work very well. But actually fighting a disease should be easier than fighting a war, because there's no need for secrecy. So I feel like I just want to put this in position, because it's very easy for me to talk to you about how I've been right and other people have been wrong. I've been wrong too, but it's not even completely clear how I could have been right. It's not like in January and February as a statistician, now I'm spending every moment working on this, right? In January and February, it wasn't like as a statistician, I was saying, how can I help? I guess we should look at this testing thing. Like, it wasn't, I had no sense of what the important concerns were, just from reading the news. I'm sure some of you were better prepared. But the messages that we were getting were, some people said, don't be scared. And other people said, yes, be scared. And so since you're scared, you should buy guns, ammo, and toilet paper. And of course, I knew that wasn't going to really help. 330 million people with guns, ammo, and toilet paper isn't going to keep the supply chain going. But I did not have a sense of the social structure of this. So this gets me to my general point here, that to be a good citizen, you sometimes have to be a bit of a scientist. And this is kind of weird, but true, that it's not a matter of just making an individual choice. Somehow good citizens have to put pressure on politicians to do the right thing, which means good citizens have to learn about science. Even though as citizens, we probably want to leave it to others. Similarly, to be a good scientist, you have to be a bit of a statistician. And I don't think scientists want to be statisticians. I think scientists think of statistics as a bunch of hoops that they have to go through in order to publish their papers or get funded, which is like kind of fine in a way, but that as we've seen lately, that won't necessarily do the job. People can get wrong answers. It's not enough as a scientist. Unfortunately, it's not enough to want to do good, to have an MD, and to be associated with a prestigious university. Unfortunately, you actually have to think statistically. Finally, to be a statistician, we have to be a good citizen, meaning we have to communicate these things. So I'll briefly talk about some issues that have come up in my own work and observations. So first is modeling. And my main message for modeling is we should be doing multi-level modeling, that everything that can vary does vary. Yeah, I'm going to be coming down in a moment. What? Wait, someone interrupted me. Is there something I'm supposed to stop? Hello? Can you hear me? I don't
You're
know.
good. Sorry, I think
you're fine.
Oh, someone told me to stop.
Yeah, you have about 6 minutes.
Oh, so who was it who was speaking then? I don't.
Sorry, I think someone.
You can keep going. You can go right ahead.
Oh, okay. Someone interrupted, so I thought, okay. So I guess I shouldn't have agreed to speak last, because then there's less time. So everything that can vary does vary, and including transmission rates and infection fatality rates and everything else. And so when we're modeling, like, we can't let everything vary at once. Maybe there are technical challenges to the model, but I think we have to avoid talking about the parameter. And especially as we integrate data from different sources, we should use multi-level modeling to partially pool and learn from these things. Another way of saying it is that we always do multi-level modeling. The only question is whether you do it right or whether you do it informally. And the informal way is 80 different research groups publish papers, and then you stare at the papers and maybe do a meta-analysis. The right way is that the data are all shared and you do an analysis of all the data at once, where you allow the parameters of interest to vary. Now, of course, the data aren't always shared, which I think is an absolute scandal. I guess it's a social choice that we've had to fight this particular war, not with a centralized government effort, but through the competitive approach of having thousands of research teams all scrambling after money and fame. So a lot of incentives to not share data. But if you don't share data, then there's a lot that you can't learn, I say as a statistician. Design. So a few weeks ago, I was involved peripherally in a clinical trial of some exciting new drug. The person who's designing the trial wanted me to give it, they wanted to get it approved, so they wanted my advice on their power calculation. They had done a power calculation based on the idea that the drug would reduce, would increase survival rate by 25 percentage points. So I said 25 percentage points seems like a lot. They said, oh, well, there was some study that said the drug increases survival rate by 50 percentage points, but we don't really believe that. 25 is reasonable. So they did the power calculation. You need about 130 people in your study. And then I said, what if the effect was 10 percentage points? Will you still be interested in this result? Oh, don't worry, it's not 10, it's 25. But, well, the effect, the effect could be 0, right? Maybe the drug doesn't work. So, oh yeah, sure, the drug might not work. A lot of things don't work. So if it could be 0, then if it works, why are you so sure it's 25? Like, oh, if it works, it's gonna have a big effect. So I think that doctor was wrong on this, and I thought about it, and here's one way of looking at it, that if the drug has it improves survival by 25 percentage points, what that does, it means that there's 25% of the population who would survive given this drug, who wouldn't survive if you didn't give it, right? So that means the drug works on 25% of the people. Now, if the remaining people, some of it doesn't work because they don't need it because they're going to survive anyway, but then there's there's another bunch of people who are going to die anyway because they're planning to apply it to very sick people who they thought were at a high risk of dying. We're not talking about just giving it out to the general population. So when they hypothesized a 25% 25 percentage point effect size, what they were implicitly saying was that they thought the drug worked on some people, not others, or in some settings and not others, right? Like maybe sometimes you're giving it too late, maybe sometimes they have comorbidity, whatever it is. Once you accept that it doesn't work on everybody, of course it could have a 10% effect, a 10 percentage point effect, or a 5 percentage point effect, because the effect is entirely based on who's in the study. If the study happens to include more people for whom of the sort that the treatment will work on, it will look more effective. If it has fewer people, it will look less effective. So I think in this case, the designer of this study had, in this case, the designer of the study was working within a conventional statistical framework in which there's a treatment effect, 0.25, and then you do the power calculation. But it misled him. It led him to design a study that was too small. It led him to do the usual thing people do in clinical trials, which is hope. It's, oh, let's gather some data and maybe we'll get lucky and it'll work and we'll save 1 million lives and get a Nobel Prize or whatever. But this is not the best way of doing science. But to get away from this hope thinking, you have to think more clearly about what a treatment effect really means and what this variation means. So I guess I do not have time for my remaining 4 points, but I guess my colleagues and I'll try to write this up in an article, and then we can send it to you. So thank you for the opportunity to speak with you.
Okay, so let's see if there are any questions. I see Yuval Ivanov.
Hi. Not sure how.
You should turn off
maybe
your
you're calling
sound.
from the phone and also having your computer on.
Yes.
So you need to put one of the two on mute.
The main message I've learned is when you're going to speak as one of 30 speakers, you should be earlier in the session so you have the full time.
No, you had the full time. You had the same time as anybody else.
Not quite.
I
had 5 minutes less. We're very sensitive academics about these things.
No, it's 12:03, and you started at exactly 13 minutes ago. So I'd say it's exactly the same time as anybody else. But anyway, so we were going to prepare to go 5 minutes late. Let's see who else is there. Margaret?
Yes, I'm here. I don't have a question at this time, but thank you.
Oh, okay. Jay Jeffries? Yes, Darcy?
Yeah, I have an observation and a question. So I, of course, agree with you about statistics. When we teach the entering class at Columbia College in Frontiers of Science, there's a very heavy dose of statistics. Whether it takes or not, and takes enough, I don't know. But for general, not just for scientists, but for the general populace, understanding statistical thinking is very important and powerful. But the other observation that I want to make is that there's been a silver lining to the lack of national coherence in the plan to combat the virus, in that I have seen more collaboration among scientists and more thought devoted to putting out this threat across universities, across labs, all data unpublished, really mobilizing, I would say, for a common foe to the point where drug companies are actually sharing things with each other, things on which they expected to make a great deal of money, including, I would say, some Columbia graduates who run big drug companies. So there's a good side to this that we should acknowledge. And this particular part is something that I hope we don't lose once things get back closer to what they were, although of course we will never return to normal. So that's an observation.
I agree. I mean, I will say though, I'm very frustrated. Like, people asked me, I was contacted by the New York Times, what do you think about this study that Cuomo reported about the coronavirus infection rate in New York City? And well, there was no report. There was no raw data. There wasn't even a report. Like, why couldn't they share it? So why is that the default is that people have tangled computer code where people ask them and they say, we're not sharing you our code because it's so ugly. And we have a study and we're willing to go on the New York Times and Fox News about the study, but we're not willing to share our data because, like, I guess, like, we want to analyze it a few thousand times more ourselves first, even though we don't have any statisticians. Like, it's ridiculous. Like, I think the good stuff is great. And I agree that, like, the fact that there's bad stuff should not mean, I don't think that scientists are bad people. I just think that we have a default of not sharing data, and that we pay for that when it comes to analysis.
I think Andy Marks has a question. Andy, you have a question you want to ask?
I had a question for Jeffrey Shaman, which was, if you, and maybe Andrew can answer it, if you model what happens when CUIMC reopens, and there's some talk about doing that in as soon as 2 weeks, with and without widespread testing and contact tracing and isolation, is it possible to do that modeling?
I will let the others answer that one. Let Jeff answer that one.
Hey, Andy, this is Eric. I don't think Jeff is on anymore.
Oh, okay.
Yeah.
Too bad.
Yeah.
Thank you, Eric. I said the same thing, but I was on mute.
I'm involved in this study. I was contacted by someone from a doctor in a hospital in Indiana. They want to do some good, and so they're going to be in the hospital. And they're working with them to do as the patient mix in the hospital varies from week to week, we can get a more stable estimate of infection rate that's not being driven by who's being tested so much. So we're hoping to set up a system and write it up in a way that's clear enough that people in their own hospitals can do it themselves and share the data. So I think in some sense, that's part of the future, is not, it's not free of all the data, but it's lots of people like working from and getting these data. So that can happen.
Is there any plan to do that here at Columbia?
Not that I know of. I mean, I'm happy to talk. Contacted me, someone I knew from elementary school, who's a doctor, and he contacted me varying from week to week, and we heard that statistical methods can be used to adjust it. So I'm hoping if we do it, that can be a model. But I guess it's like people just collaborate where they can.
So Darcy, do you have a follow-up question?
Yeah, I actually sent this email to Jeff Shaman. It strikes me, well, first of all, as you must all realize, that in addition to the medical workers, people in research laboratories are chomping at the bit to get back to doing research, particularly the students and the postdocs. And it struck me that and there is an effort at the ZNBVI that you guys should know about. There's a Slack channel, and this is an effort for home testing and contact tracing, and it's kind of complicated. And probably you could talk to Marjorie G or to Andres Spaghetti about it. I think it's a very clever effort.
I think we're going to have the presentation of the next symposium.
Okay, so you'll learn about that. But it struck me we have an opportunity to do an interesting statistical study of best practices in research buildings. This would apply to hospitals as well. So all of these buildings have essential workers in them, right? And they're sparse. They're animal caretakers, and in some cases, people doing COVID research, and in other cases, people doing quote unquote mission critical research, whatever that is. And so you have a bunch of these places all over the country, but we have here lots in New York City. It's the best place to do with Long Island and New Jersey. So we could actually look at those places and their practices for their essential workers to see if any of them seem effective in reducing risk so that we can go back to doing research safely. And that would be a big plus for science because, as you all know, basic research is what produced, PCR. Every moment that we stop basic research sets us back by much more in terms of confronting the next virus. So we all love working on this virus and thinking about it, but we also want to do the things that drive us. And I think we need to know this. If we go back to work and the grad students start getting sick, we'll be in trouble. So I propose that to Jeff.
One reason that I was kind of even in February when I didn't know anything, one reason I disagreed with people who said that we were panicking was that at the very least, this is a good dry run for what we should be doing when the bigger thing comes next time.
Okay, I think we should have one last question because now we are 7 minutes over the time limit. And Margaret, you have a question?
Yeah, it's a question / concern, and that is that I'm increasing concern about data silence insofar as that, the data with regards to the ethnic makeup of people who are suffering from this, and that seems to be kind of dropping out of some of the discussion. And then the other thing is that, I do think that we have to be, while this presents opportunity clearly in terms of research, or so, I do think we have to all be careful to check that with the reality that massive numbers of people are dying and still expected to die. And so I understand and appreciate the opportunity, but just also want to draw attention to that. And I would be interested to get other people's thoughts on that.
I don't understand the contradiction because the purpose of the research would be to target resources to reduce the number of people dying. So it doesn't seem like it doesn't seem like a trade-off, like you're doing research instead of being concerned about people dying. I would say like there's the allocation there's direct application of resources like sending doctors and nurses places. A lot of the question has to be resource allocation, and there I think research is kind of necessary.
Yeah, I didn't mean to imply at all that research is not necessary.